Taking care of babies withdrawing from opioids has really changed in the last decade. We've gone from mostly treating these babies with medication, so pharmacological methods, to really emphasizing non-pharmacological methods or just giving them a lot of comfort and support to get them through this very difficult stage of withdrawal. I'm sure for some of the bedside nurses watching this that have literally had to cuddle and console babies all night long, some of you kind of missed the medications a bit. But as we'll discuss, the data is really pretty convincing about how much better the non-pharmacological treatment is for the babies. If you haven't already watched the last video on what is NOWS, or neonatal opioid withdrawal syndrome, then go back and watch that. In this video, we're going to be talking about the management of NOWS. So 1, how do we decide whether to treat a baby? 2, non-pharmacological methods of treatment. And 3, pharmacological methods of management. Hello, I'm Dr. Tala, and I've been a neonatologist for 17 years now. And like I said in the last video, we were asked to cover this topic by our members. So if you're interested in that sort of power, then please think about joining our Feeder Grower community. Right, let's start. 1, when to treat a baby. As we talked about in the last video, a large part of actually managing NOWS is figuring out whether baby is actually withdrawing or not. We're not just going to start giving medication or even non-pharmacological management to every single baby whose mother had a positive urine drug screen, or even if the baby had a urine drug screen. They may not actually be withdrawing from those drugs. And the way we decide which babies we should be treating or not is by scoring the babies. And we score the babies based on how frequent their symptoms of withdrawal are and how severe their symptoms of withdrawal are. And the higher the score, the more likely that the baby needs closer management or even medications. The most commonly used tool in the US is a modification of the Finnegan score. And the Finnegan score was developed in 1970 by Dr. Finnegan. And this score includes 21 different elements. So really pretty time consuming to be at the bedside and to go through every single one of these. And you can see all the different attributes of the score here. So depending on what the baby's doing and for how long and how bad it is, they'll get a higher score. For example, if there is a high-pitched cry for less than 5 minutes, then the baby gets 2 points. If there's an excessive high-pitched cry for above 5 minutes, then the baby's going to get 3 points. If the baby sleeps for less than 1 hour after a feeding, then the baby gets 3 points for that. Baby will also get other points for increased tremors and a hyperactive Moreau and excoriations and yawning several times in a row and sneezing several times in a row. So basically, all these points are added up to give the baby a final score. Another variation of this score is the mother score, which stands for Maternal Opioid Treatment Human Experimental Research, which is a 19-point score, pretty similar to the modified Finnegan. But this was the score that was used in the study of trying out morphine versus buprenorphine, which is Subutex in that study. Again, depending on how the baby is behaving, you're going to get higher points for that. So kind of the same thing, excessive yawning and less sleep and more irritability. And again, you tally up the scores. As you can see, these are pretty labor intensive and you're doing them pretty much every 3 hours. In the mother scoring system, if you got scores between 9 to 12 consistently, or you got one score above 13, then that baby would be started on medications. More recently, and this has been pretty fantastic, a different scoring tool has been used increasingly to determine whether you should be treating for NOWS or not. And that is called the ESC, or the Eat, Sleep, and Console scoring tool. So the scores with this one are E, can the baby eat more than an ounce of breast milk or formula, or can the baby breastfeed well? Sleep, can the baby sleep for at least an hour between feeds? And console, can the baby be consoled within 10 minutes? That's it. That's what you're testing for on all these babies. No more 21-point Finnegan score or whatever. And if the answer is no to any of these, so the baby isn't eating, or the baby isn't sleeping, or the baby can't be consoled, then the team needs to readdress the non-pharmacological management. And if that's kind of maxed out, then at that point, the team decides that it's time to give medical management to the baby. There has been lots and lots of encouraging data on the ESC approach. A recent study in the New England Journal of Medicine showed that by using the ESC approach, it can reduce the number of days that a baby spends in hospital from 15 to 8. So a significant difference in hospital stays. Also, the babies that were under the ESC approach were obviously given significantly less amounts of the opioids themselves. Obviously, it's important that whatever hospital or institution that you're in, everybody is doing the same thing. They're using the same score. There's a protocol in place for what happens if a baby isn't doing that. Are you still going to give PRN medications? Are you going to do other things non-pharmacologically, or are you going to start a medication and then wean it down? So there are still decisions to be made, even if you are using the ESC approach. So how long should we be observing and scoring these babies for? So like we said already, after a baby is born and we're worried about them actually withdrawing, we have to watch them for a certain period of time in the hospital. And when we say watch them, really we're scoring them. So whether it's the ESC score or the modified Finnegan or mothers, this is the way that we are objectively observing these babies. And we discussed in the first video that the length of time that we watch these babies for is going to depend on which drug the mother was on. If she was on a drug with a long half-life, like methadone, then these babies need to be observed a lot longer until we're absolutely certain that they've gotten over the hump of actually going into a withdrawal. The AAP clinical report on NOWs recommends that we observe babies that were exposed to immediate release opioids for 3 days, for intermediate release opioids for 4 to 7 days, and for long-acting opioids like methadone for 5 to 7 days. The next question is, where should these babies be observed? So in the US, at least, a mother will stay in hospital after she delivers a baby somewhere between 24 hours and 4 days, depending on whether it was a vaginal delivery or if it was a C-section. So if that mother was on methadone and that baby needs to stay 5 to 7 days, then we need to figure out how ideally we can keep the mother with the baby, even if the mother has been discharged home. These mothers also need to know that babies do have to stay for observation. And I'm sure you've all had lots of mothers who have been very angry that they didn't know that these babies do need to be observed for withdrawal after delivery. If the babies are staying with the mothers and they begin to look like they are actively withdrawing and they may end up needing medications, then at that point, we really should be admitting them to the neonatal intensive care unit so that we can observe them more carefully and see whether they are going to need medications or not. We don't give medications to babies when they are not in the neonatal intensive care unit. We don't give opioid medications to babies. But this is where the huge problem arises. The NICU, if you think about it, is a horrible place to put a baby that's withdrawing. For starters, you're most likely separating the baby from the mother. So you're already affecting the bonding and affecting all the non-pharmacological care that the mother is able to give the baby. That in itself can make withdrawal worse. But on top of that, think about the NICU environment. It's loud, it's bright, it's very overstimulating. So again, that is really not good for babies that may be withdrawing. Really a rooming in situation. So where the baby is under kind of the NICU care, but a private room or a private area where the mother is able to stay with the baby is really the ideal scenario. So the baby is getting all the bonding and the non-pharmacological care from the mother, but also it's not in that kind of overly stimulating environment. And studies have shown that when there are rooming in rooms for babies with NOWs, generally the babies have a shorter hospital stay and have less need for pharmacotherapy. 2, now let's cover non-pharmacological care of babies with NOWs. And as I've been alluding to, there is increasing amounts of research emphasizing the importance of non-pharmacological care in babies that may be withdrawing. In November 2020, the AAP, or the American Academy of Pediatrics, published their recommendations on what should be done for babies with NOWs. And again, they really emphasized all the non-pharmacological aspects first and really lean into those as much as possible before medication is started. A study was published in Pediatrics in 2024, which compared basically how babies did before this policy statement came out and after the policy statement came out. And as would be expected, after the policy statement, fewer babies ended up needing pharmacotherapy. So 50% in the later group versus 59% in the earlier group. So it does cut down on opioid exposure to these babies, this non-pharmacological emphasis. So where does this non-pharmacological care start? Well, from right after delivery for the mother. These babies can be really, really tough. They can cry. They have a very piercing, high-pitched cry. They are just very irritable. They don't sleep well. They don't eat well. It's very, very difficult patient population to take care of. So these mothers who are probably already grappling with guilt and anxiety are now having to deal with this very difficult baby. So you can imagine how much support mummies need to get through this. So really the first aspect of non-pharmacological care is to give mothers the support that they need, which means that we are treating them with kindness and in a non-judgmental way, whatever they ended up taking, that we literally help them out with feeding the baby, that they get the lactation support and any other nursing support that they need. The mothers need this and the babies need this. Now let's cover the different aspects of non-pharmacological care for the babies. And probably the best studied one is breastfeeding. This has also actually kind of changed quite a bit, that we all used to be a little bit worried about the amounts of drugs that were in the breast milk and the baby was getting it. Now, really, if it is a legal drug, or the mother is on methadone or buprenorphine, which the vast majority of the time it is given legally, then we do allow the mothers to breastfeed these babies. Often, this really low dose of the drug that the mother is probably still on, getting through to the babies through the breast milk, is often enough to stop or to control the symptoms of withdrawal in the babies. But again, you can imagine how difficult it is breastfeeding these babies. They are angry, they are irritable, they are poor feeders. So again, it's going to be really important to support mothers with good lactation specialists and to keep encouraging mothers to work on the breastfeeding. Going beyond breastfeeding, like we said, a really important part of non-pharmacological care is keeping the mother-infant dyad together. So a place where the mother can hold the baby, they can do skin to skin, and family members can continue to console and take care of the baby. And like we talked about, the actual environment that the babies are in, we want it to be a quiet, non-stimulating, non-bustled, just very calm environment that hopefully the mother can stay in with the baby. As we all know, unfortunately, sometimes this isn't the case. Sometimes the mother leaves as soon as she delivers the baby. Sometimes the mother knows that the baby is not going to end up going home with her because of legal reasons, and so she has no interest in bonding with the baby at all. In these scenarios, obviously, the ideal thing is to get a very invested family member that will kind of take on that role of the mother and be there to support this baby through this. In some units, there are also volunteer cuddlers that can sometimes give the babies they love, they need. But in the cases where the mothers aren't there, unfortunately, a lot of this non-pharmacological care does fall onto the nurses, and it's not easy. And so obviously, there needs to be some sort of system to make sure that the nurses aren't getting burnt out as well in taking care of these very difficult little babies. And for the providers in the NICU, we really should be interrupting these babies' sleep or just when they're quiet as little as possible. So we should ideally be trying to cluster cares with the nurses when they're feeding them or changing the diaper or whatever, just so that we could try to enable them to have as much peace as possible. Really, that's true of all babies, but as I know you all know, that isn't always possible. The last thing that I'll say about non-pharmacological care is that the AAP really emphasizing in tailoring the non-pharmacological care depending on what's really triggering the baby. So if the baby really can't handle bright lights at all, then make sure the lights are always dimmed. If the baby is really having a lot of tremors and is hypertonic, then make sure that the baby is being swaddled. A lot of babies like those little swing things that really relaxes them. And so ideally, we would have all these toys in the ideal environment set up to try to soothe these babies as much as possible. 3, medical management. So let's say that you have been giving the absolute ideal non-pharmacological therapy. You're keeping the baby in a nice, soothing environment. The baby's being breastfed and held and loved. And even with that, the baby's symptoms are extremely severe, or the baby is losing weight because it's eating so little and the stools are so loose, or the baby's got such a horrible diaper rash because of the loose stools and the baby has failure to thrive. At some point, we do end up needing to treat these babies medically. The way that we used to give pharmacological therapy was that if the baby's scores were high enough, then we would actually start the baby on a consistent medication. A lot of units ended up using morphine, and we would give that drug and escalate it or titrate it depending on the baby's symptoms. And babies would often end up on these drugs for days or weeks, sometimes even months, just kind of slowly going up and down based on the symptoms. And as another quick aside, this was also something really bad about the Finnegan scoring. If the baby was a month old and the baby was just awake more or would just get agitated more because it did want the stimulation that a regular 1-month-old would want, then they would score higher. So the Finnegan scoring was really not ideal as babies got a lot older. Now, though, all of that has changed because if your unit is using the ESC scoring tool, then we are in a position where we can still just give 1 dose of morphine PRN. So if the baby in the last 3 hours hadn't slept at all or hasn't been able to be consoled within 10 minutes, then we can give them 1 dose of morphine. We're not committing to give it to them around the clock for the next few days or whatever. In treating now, because the baby was exposed to an opioid, then we should be treating with an opioid. And probably the most commonly used drug in the US at least is morphine. Previous studies have been done with using methadone or buprenorphine, which is the Subutex, which are both longer acting or have a longer half-life than the morphine. And various studies have shown that maybe using methadone or Subutex actually does decrease the days of hospital stay. But a lot of these studies were done with the Finnegan scoring rather than with the new ESC scoring, especially if you are in a unit that is just giving those doses PRN. So for example, if the baby is withdrawing or whatever, you just give that 1. You're not committing to be going up and down and titrating a drug. So even if a baby is following the ESC scoring and is consistently having these symptoms, so for example, whatever dose of morphine that you may be giving PRN, maybe it's 0.03 mg per kg or 0.04 mg per kg, and you're basically consistently having to give this every 4 hours or so, at some point you're probably going to want to put the baby on a maintenance dose and just keep that going around the clock, trying to control the symptoms. Sometimes you have to escalate the dose because even on your initial starting dose in your unit, whatever that may be, you are still not controlling the symptoms of the baby. So you carry on marching up on your dose, and eventually at some point, if the baby's still having symptoms, on a higher morphine dose, whatever dose your unit decides, whether it's 0.1 mg per kg, then sometimes the baby needs additional medications to try to help control it because you don't really want to go any higher on the morphine and make the baby completely sleepy and lethargic from the morphine itself. In these cases, some secondary medications are used like clonidine, which is an alpha-2 adrenergic agonist. And this kind of works synergistically with the morphine and can really help that last little bit of withdrawal control that we need. Phenobarbital has also been used classically as a secondary medication in withdrawal. Again, do not use these as primary medications. They are not opioids. So you may be feeling a little bit better because the baby is more sleepy, but the baby's symptoms aren't truly controlled. And once you started treatment or once you're observing the baby in the hospital, how long does the baby have to stay there? Well, we, as of now, do not send babies home on any of these medications. And so generally, we want the babies off the medications for at least 24 to 48 hours to make sure that the baby isn't having any withdrawal symptoms. And we also need to make sure that the baby is eating well, is gaining weight, and the mother or whoever is taking care of this baby at home is capable of doing all these cares for the babies. It's one thing if you have the best primary nurse on the planet that's been able to take care of this baby and feed the baby, but then the mother is completely incapable of actually dealing with this little very angry baby that doesn't eat very well. So it's very important to set up a as good as possible home environment before these babies go home. Okay, that was it. What do you all do in your unit? Are you using the ESC guidelines? Do you love it? I'm sure if you're a bedside nurse, then you've got a few things to say about it as well. But overall, we do know that it does decrease the amount of pharmacotherapy that these babies are exposed to, and it decreases the length of hospital stay. I hope that you enjoyed that. And again, I want to thank you all for being here.